Aziz from the Ministry of Health, could you, 400 doctors per year graduated. This is, I can guarantee this is from the University of Tripoli only. Could you imagine how many jobs you have to create for the next 5 to 10 years? Well, we have a good number of doctors working in the sales and drug stores, and many of them are representatives for drug companies. We have a lot of fifth-year students, resets. They are really a problem for the Faculty of Medicine in Tripoli here. Well, according to WHO studies, only few nurses considered qualified in Libya. And I can say that out of the 40,000, only 500 nurses considered to be qualified in Libya. Graduates of nursing schools are undertrained and poorly qualified, which is quite clear, They have a lot of social problems, loss of respect from society and doctors, which is quite clear as well in our hospitals, and poor English language at last. Well, as you know, less than 40% of the total number of employees are administrators. How we can solve this problem? Do we need to re-employ them, create a new job, upgrade them, reviewing their salaries because they are complaining that their colleagues on the professional side, they already increase their salaries, while the administrators, they don't increase it. Well, if you want to see the criteria of recruit professional or healthcare personnel, you can just come across or search in the internet, and you will find a lot of sites talking about that. The question again, do we need more staff? And to retain people, we have to satisfy them. How? As I told you, we need a workshop or a discussion group to answer this question. But generally, we have to put a strategic plan with smart goals, considering feedback from the staff, incentives. You can't send a doctor to an area where there is no decent coffee shop to spend an evening with his family. It's a cluster. I'm sorry to say there is no other sectors representatives in this conference. I would like to see representatives from the planning ministry, from the education, from the economics, so that they can share us our way of thinking. And lastly, re-employment, create new jobs, and discipline code, which is very, very, very important. Thank you very much.
Thank you very much, Dr. Badruddin, and I don't blame you actually to retire actually, but I think it's, again, it's a matter of quality and not only the quantity of the people, but we have a lot of discussions, I think, in the workshop about human resources, and we can allow one or two questions, please, and we'll see. Yes, please. Yes. Yeah.
Assalamu alaikum. Dr. Abdul Hamid Fillah, consultant anesthetist, retired from the government work since 2005 because I couldn't cope. Regarding the data that Dr. Bohjar gave us, they are true data, but what's behind this data is not true. I have been asked in 2008 to join one of the committee to retrain the nurses. And I've been shocked when I heard one responsible guy from the Statistic and Documentation Department to tell me that we have 75 registered nurses. 75,000. And he wants to retrain them all. The fact is, when you look at this number, you will find a very good number of them, about a third, are actually not nurses. They are agents to the internal security and the internal intelligence and police business and all that. And we have exposed them during the 17 February revolutions because they are the ones who were writing reports about doctors and all that.
So it's not 75,000.
It's
around 50,000.
okay. Now, the other one-third are registered nurses, and they are got paid while they are staying at home. Just because they know somebody working in the health authority and they give them salary and they stay home. They have no relation to medicine whatsoever. So we have got left with 25,000.
Okay.
The 25,000, 20,000 of them are not upgradable because of the bad educational system in the nursing education. Okay? So they can't be better at all.
Is that you saying so we do not have nursing staff?
So when I said we have got technically about 2,000 or 3,000, we can get used of them, and they are upgradable. They didn't call me to any other meetings. I've been sacked from the committee, and that's the story. This is what was Libya. How bad was it? We have got a very difficult task ahead of us to restructure the health service. The data are true, but false. The high rate of administrators in some hospitals.
Yeah, thank you very much, Dr. I mean, you raised some.
Yeah.
Sorry to interrupt you.
So we really need to.
We got the message. It's inaccurate data we have now.
The data, the numbers are true,
Thank
but need revolution.
Thank you very much. Take care.
Yeah.
Well done.
I think one more question from Dr. Khalid Al-Maghboub or something. Yes. Yes, please. Do you want to say something, yes? Or to ask a question? One of you.
Yeah, thank you very much. We got the message, the same comment. Is that okay to go to the next?
Can I make a comment as well?
That would be taken from your time then.
Remind people that nurses and doctors don't look after only inpatients. They have outpatient work, and I think it is a little bit unfair to compare that with the bid numbers that way. My unit in the UK, my intensive care unit, has 20 beds. They are all level 3 patients, so they all need one-to-one nursing. But for 20 beds, we have 135 nurses. So you don't have 20 nurses for 20 beds. This is not, to staff one bed fully 24 hours, you need 6 to 7 nurses.
Thanks. Thank you.
So that's the point.
Well, next speaker, I'm sure you know him already, Dr. Murad Greu. He is a consultant in respiratory and intensive care unit at Salford Hospital, Manchester. And he will be talking about the ABCs, training and continuous medication. Is that what yeah.
Yeah, I'm afraid because it came under the human resources, my topic, I thought, was mainly to do with workforce development and training. So it is not about training undergraduate and postgraduate doctors, which is unfortunate, I think, because most of what I was going to say has been covered. But I'll try to say something new if I can. So what I'm going to do is to talk about the reliability of care and how the concept affects workforce development, and talk about continuous medical education, whether we want to call it CME or CPD. But I'll start even with something totally different, which is a reminder of what has been discussed yesterday, the evolution of clinical governance and quality improvement. And in 1995, the UK was here. We had healthcare service, we had resources, hospitals and doctors and workforce and so on, and we have structures, buildings, equipments and so on, but the service didn't there was processes, there obviously it did work, but the processes were not mapped very well, and it is not defined clearly. So from there, we went into clinical governance. The concept of clinical governance came up, and it started with talking about defining processes, introducing clinical guidelines, protocols, policies, not necessarily for clinical work, protocols and policies for everything within the hospital. And that's the start of quality improvement, I suppose. And it has been stepwise change. So the next step was, do we know that our guidelines and processes and policies that are supposed to be going on within, or we are supposed to follow, are they being followed, and how effective they are? So we started introducing these concepts. We monitor, we need assurance on quality. We need to have data to show that we are following these guidelines. And we are doing what we are saying we are doing. And if you have evidence that you are doing everything correctly, 95% of the time, that's the measurement of reliability. So if you do things the way you think correctly every time, then you have reliable care. And by that, I mean, think about that in Libya. When somebody has chest pain in Murzug, and he gets seen by a doctor within 20 minutes, ECG within a few minutes, and clinical decision is made whether he had myocardial infarction, and if he had infarction, he will get PCI now within the next an hour or so, then you have reliable care. And I think we are way far from that. Then we start think about improving the quality even further by doing qualitative research, introducing new ideas, trying tests of change. The methodology is a very alien concept to doctors because we are used to quantitative research. We like evidence-based medicine. We like randomized controlled trials. But it is not followed in the social research like this. It is more of you do a little change and see whether it works, and if it works, try it in a wider way, and if it works, then expand it, and so on. And once you get there, well, you don't have actually to follow these steps, but this is what happened in the UK. Now we are talking about efficiency and productivity, and I guess the drive behind that is the economic crisis. But can you deliver good quality care with limited resources? So that's where the UK is, and I think that's where we are in Libya. And we have to do this Whether it is stepwise or we do everything, I'm not sure. That's for debate. Now, in terms of workforce, do we have mobile one? No. When we follow these steps in workforce development, we have doctors, we have nurses. We don't even know whether our nurses are qualified to be nurses or not. We heard 700, 656, something. So you need, even if this workforce is fully qualified, you need to have a training program. You need to have training program, partly to make sure that they maintain the skills and acquire new skills as medicine evolve. As medicine evolve, obviously you need to acquire more skills, and you have to prepare for the future. So you have to have a training program or personal development program for the individual. And then you need to monitor the quality and effectiveness of your training program. Is the training program delivering what you want? Are people actually learning or just signing for that? And are they compliant with the mandatory training, if there is mandatory training? And then every individual should be appraised to see where they are and have personal development to plan to prepare him for the future. Now, I deliberately here removed or omitted values and behavior. And I don't want to irritate Mr. Bourne, because if you really want to irritate UK consultant, talk to him about values and behavior. But I think we are okay with goals and objectives. I think everyone should know what they want to do with their life, with their career, what they can offer to their institution. And your goals should be matched with the goals of your institution. And then even the UK is still struggling with this concept. So I think we better not to talk about it. Now, this is taken from the WHO, World Health Organization, in the report from April 2006. And it talks about strategy for workforce and how to manage it, and recruitment, managing exit, and so on. But the aim is effective workforce. And in addition to having systems of support and so on, you need to have lifelong learning. You don't stop. You qualify and you get appointed as a nurse, and that's it. You have to learn throughout your life, partly to keep the skills up to date, but learn new things. You learn new things because medicine evolves, but also because you have to evolve within the system. And if you can't see the light, you get withdrawn, to what becomes boring, and you get burnt out. So, and I'll talk about that in a minute in more detail. So this is another extract from the World Health Organization. This is a recommendation for a country, what they need to do with their workforce if they want to have a plan for workforce development in 10 years. And knowledge and developing their skills and so on is core things within that, in addition to their satisfaction. Now, I'll skip the workforce planning because it was already talked about. But what I want to stress on is that workforce development is primarily the business of the employer.
you don't leave this to the individual person to plan for his development, to learn in his own time. Well, they should learn in their own time, but they shouldn't be left to plan their career on their own. And if you do that, that's what's happening in Libya. People go in different directions. You will have chronic junior doctors who gets nowhere. This is the fault of the system. It's not their fault that they are where they are, because the system didn't give them the opportunities, the incentives, the conditions to evolve within it. You get any doctor, whether they're intelligent or subnormal or whatever in the UK, and they will progress. Maybe at various rates, but they will progress. Because the system doesn't allow them to stand still. You have to develop. And it is the employer who should do that. And it is in the interest of the employer to do that. Everybody should have personal development plan. And in addition, if the employer agree with his employee what he's going to do, how he's going to evolve and develop his skill, what he wants to do with his life in the future, career-wise, then they can come to agreement that both useful to the employee, but also motivates him, makes him work harder, and try to achieve. And when they do that, that will reflect positively within the organization. So that, what I meant is personal development plans should fit with within the strategy of the employer and also meets the expectation and the aspiration of the employee. So the idea that you have a doctor working in the urology department and then gets sponsorship and he will go and do anesthesia, for example, is completely wrong. This means that there have been no thinking, no discussions between the employer and the employee. They were not interested in him. They're not supporting him. So now I'm going to move to CME whether we call it CME or CPD, but why we need this? It is a necessity. We have to provide evidence that we are engaged in CME or CPD, partly because within the UK you have staff appraisal, you have to review your personal development plan and agree what you want to do next. You need to submit that for re-registration and revalidation. And if you come before the GMC, you can't defend your practice if you didn't demonstrate that you have kept up to date your skills.
You've got 5 minutes. So.
Okay, right. But it is. I'll stress back on this, that it is in the interest of the employer that the doctor has, or the employee has full engagement with the process. That why I prefer to call it CPD, because doctors are not only doctors, they are scholars and scientists, they are professionals, they are clinical managers, and you have also mandatory training sometimes that has nothing to do with medicine at all. So to fulfill all this role, your training needs to be more broad than just simply training to update your clinical skills. I'll skip these ones. This is example from the Royal College of Physicians, what kind of continuous professional developments that doctors should engage in. So they classify it into clinical, non-clinical, distant learning program, and here we got the clinical up, so it can be external, internal. It is mandatory to have certain internal points within the UK, external points, sorry, within the UK, 25 hours per year. In the States, I think they're a bit more. You can have as many internal points or personal points as you want, but generally you require 50 points to have full acceptance and certification by the Royal College. And at the end of it, it will show that you have been following, you have good CPD record. They will give you a certificate that you can submit it to your employer to show that you have been fully compliant with the CPD process. Now, CPD activity generally have to be accredited and recognized by accrediting or licensing body. Usually it is the Royal College in the UK, because it has, well, not every event will be classified as a valid CPD activity for very good reasons. I mean, you attend, I'm a respiratory physician and intensivist. If I went to event dealing with cognitive behavioral therapy, that will not be considered as CPD because I don't need this really. It's not within my profession. So the need is important, whether the need, personal need within your specialty, local need, or national need. If there is something, I mean, say during the influenza epidemic, people needed to update their knowledge and skills on how to handle influenza, how to recognize it, and so on. And this was generic, so everybody had a training, and it was national need. You need to demonstrate for the accreditation that the body providing this activity is credible and it is appropriate for the target group for the reason I said. And also you have to submit for accreditation for quality assurance purposes. For example, I got here is that for hands-on procedures like echocardiography training, for example, you will it should be like 5-6 people doing hands-on procedure. You can't bring echocardiography machine here to audience of this number and show them what to do, and then you call that a training. It will not be acceptable. You have to provide feedback history. That's why people insist about distributing feedback forms and try to persuade you to fill them, because the accreditation body will look at your history as a provider and see whether they will give you that accreditation again or not. And you will need to declare your interest as a sponsor. So if a drug company comes and do presentation about an antibiotic and say this is the best antibiotic in the world without giving evidence and talking about equal choices and declaring their interest from the start, it will not be counted and accredited. And usually the college will check the content of the talk as well. This is, I think we can stop after this, but...
Last minute. Yeah.
Okay. Now, once you have been trained, then in skills like practical skills, your competency has to be checked. So if you did echocardiography course, you have to be assessed and certified competent. And there can be level of competency, but without certification of competency and assessment, you can't claim that you have been trained. And then, as you go within your career, you have to demonstrate evidence of retention of competency. If you are doing high volume practice, like say somebody doing echocardiography every day, then what they have to demonstrate is that they have satisfactory outcomes through audit process, and that will be sufficient to show that they are competent. If your practice is low volume, you do the test or the investigation or whatever it is only occasionally, then you have to show that you have regular training sessions to update your skills. Otherwise, you will be incompetent. Doesn't mean that you are not a good doctor. I haven't done liver biopsy for 10, 15 years. I can't claim that I will do it now. It was a routine thing, but I can't. It will be undefendable if I did liver biopsy and the patient died. And that's it.
Thank you very much, Dr. Murad. can I just comment here? It's obvious from the previous speaker and also from Dr. Murad that actually what we have, we are really sure we are overstaffed. We have too many doctors and nurses, but we do not have information on them. I think baseline information is lacking. Number two, what you have talked about is really important, is to develop these staff. And I think these are one of the corners of the clinical governance. Thank you very much, and we'll take the questions. Yes, Ikram.
Thank you very much, Dr. Greu. I like your presentation. Just I wanted to mention about the human resources. They are the main resistant to change everywhere. In every organization, the main resistant to change is the human resources, the people. So what makes things here different is you are talking about the community or a society where people can plan for themselves, for their future. Here we have a problem in our country. If you ask, let's say, a nurse or a doctor, what do you want to do after 3 years from now, he can't give you the answer. And I have my experience. I made a lot of small courses for the people to build their vision, and actually when I asked it, what's your plan for the next year, nobody answered. So this is the problem. You need to start building capacity, and you should start with I think a guidance in each organization, and investing in people should be monitored by completely independent organization outside the Ministry of Health. They should test every organization if they are investing truly in people. That's why a plan couldn't be done by the individual himself. So he should be trained how to plan for himself. I think this is a preliminary or the initial step before we maintain we configure both the strategy of person and strategy of the.
Thank you very much. So just a comment, wasn't a question.
Okay, well, I'll comment back about that. I agree with a lot of what you said. The leader has to motivate his staff. I think people here don't have plans because they are lost. Nobody is guiding them. Nobody is supporting them. And no vision. Okay. So the point I wanted to stress on, it should be the responsibility of the employer to motivate, support, encourage staff to develop. And it is in the interest of the employer. And it was said already that we have too many general surgeons, but we have only 1 or 2 radiologists. Now, if the Ministry of Health have what they need, they have workforce survey and so on, then part of their plan is to motivate, give the incentive, start planning to develop their force, direct people that way. If we leave things as they are, then I don't know. I mean, when people go abroad to study for higher degrees, sometimes they tick the boxes, rare specialty or something, because they will have more chance to get sponsorship في وزارة التعليم العالي. ولكن when they go abroad, they quite often choose the pathway that is available to them, because they have no vision, as it said. They don't have a plan in their mind. So, okay, I'll fit wherever I can fit. And then, naturally, you will find people coming from mainstream specialties where job opportunity and training program are easily accessible.
Thank you very much. We'll take from the back. Yeah? Sorry, misunderstanding. It's okay. I thought it's a comment, not a question. Good. It's no problem.
Thank you so much for this very clarifying, CME points. The main thing which I should say that in this morning, sorry for my voice, we agreed with one of the doctors from Chicago and somebody from Ireland, and I started the work with people around here about CME. And the best thing is just to make plans, make programs. And we know all of us, I was a graduate in 1983, but at that time we had a very good system. When I went to England, within a year I got my MRCP and I started to work. So Libya had a good time, and we want to go back to it. The main thing is just to put plans. Before we go home this Thursday, we're going away for a picnic on a Friday, so we come back on Sunday, we have plans. That's what I hope that we should do now, and the leaders should be the people, the consultants, which most of the time are not available in hospitals.
Thank you very much.
And we hope we work.
Yeah, we
Thank
got the
you.
message, thanks. Yes, and the other side, yeah? Yes, please. We'll come to you. It's in the back, just a minute, yeah. You have,
Huh?
you'll be the next, okay?
Me or?
Yeah.
I'm sorry. Good afternoon again. Thank you very much for a very nice, interesting lecture. I do remember in the last year when I was there in the UK, when all these paperwork filled our life and the nurse's life, there was a complaint from the nurses first and then from us, the doctors. There is no time for the patient to fill all these papers. That was initially the impression. You know, there was a lot of paperwork, a lot of. You mentioned in your lecture that in this ladder of progression, the National Health Service was doing fine in the 90s, but there was no records. There was no, centralized databases and all these new technology and health information systems and hospital information systems to record the good things and the bad things and take action about it. But there was audits going on. There was continuous improvement. But the people, what is important, what I mean is, first is the patient satisfaction. My question is...
Yes, please. Can you ask the question quickly? Yes.
I was about to ask it. That with all these measures, with all these complex programs and websites and everything, the patient satisfaction rate in the UK, has it changed a lot from 1990 to 2012? I've been away for 5 years now from UK, so I don't know.
Thank you very much.
You.
Okay, I think I can answer that. Unfortunately, you can't avoid this paperwork. It has to be done. You can minimize it. You can minimize duplication because you probably know that things are written. There's no voice? So you can minimize duplication. You can sort of try to streamline the process, but you can't avoid this paperwork. You need data. We think things were safe then, and maybe nothing has changed, but the evidence is not that. The evidence is completely against that. In 95, we used to see central line infection as normal. Normal event. You put central line, some of them get infected. In 2002, in my unit, we had incidence of central line infection of 1 in 50. Because we collect data, we deal with things, we try to improve our infection control. We had no central line infection for 3 years now. In 2008, MRSA acquisition within our unit was 4 or 5 cases every month. It is less than 1 per quarter at the moment. And we only know that because we collect data, and at the same time, we invest in training our staff. And without having data, you can't have development. You need to know where you are now, and then you do something and study again and see whether that makes change. And this is one of the bases of quality improvement. Some people call it radar cycle. The European foundation for quality improvement have different name for it, but the principle is you study, you have data, you do something, you study the impact.
Thank you very much. We're running out of time. We'll take the last, question from the front.
Sorry, it's not a question. Assalamu alaikum.
Assalamu
I will be a little bit defensive for my colleagues in Libya here, because I was here in Libya and didn't went outside. And I'm one of the chronic GPs here in Libya, whether if you want to call it as chronic GP. And the last years, thanks to God, that there is a plan was done for a consultant GP, which was anyway. The problem here was there is no plan for nothing. There was no vision for nothing. And thanks to some of our colleagues here, which they tried to do something in the earlier time, you see, and for the people who were suffering here, this chronic GPs, they were suffering here actually, with the very bad salaries, with very bad training, with very bad even acknowledgement of their service, which they did provide in very bad time. And I think if you saw something in the last lectures about how still that health services still going good in Libya, although there is no challenge, nothing of education, training, nothing, you see. And then one of the doctors who stayed here, and they stuck, maybe I would say stuck here in Libya, maybe they didn't get the chance to go out. And I wish in this conference that you reach something how to help these people who did suffer, who did cover your absence in Libya, and to try to take them up with you and to support them to pass by this chronic GP problem.
Okay, I got the point, and I'll comment back. I hope I didn't give the impression that I'm blaming senior doctors. I think the best thing in the healthcare system in Libya is the doctors, because they are swimming against the current and they are trying their best. But you can't, as a system, you can't rely on goodwill. You have to have system in place. Whether you are honest or not honest, you are religious, not religious, you are nice man, not nice man, you have to do what is expected from you. It happens that Libyan doctors are nice and have goodwill and they try to stand.
We'll declare something, okay? Let's first, I will give you an example for the quality, because we are discussing quality issue. I'm one of the first people who trained in Libya for the quality, you see. We are 5 years training up to now, and we didn't even get a diploma. Only training courses, and a lot of universities came here to give us a diploma in this issue.
Yes.
And up to now, we didn't reach it. So just I want to tell you that there was no system. No, nothing.
I think we got your point. Lack of strategic planning. Can I just ask you for a favor? The last question, please. The gentleman in the back, and we'll stop. Is that okay? You got to forgive me for this, because he's been raising his hand, and I feel guilty about it, really. Thanks. The last one. Yes, please.
I would like to thank the speakers, and especially the last two speakers, actually, who took us in a journey through theoretical to all the way to a very painful data and realities. Now, what is first, egg or chicken? Shall we actually have a good system and then leave the people actually to run the system, or we upgrade the people and later to bring another system, or let them actually create the system that suits them? Here, actually, I would recall what my professor said last week, Dr. Beit al-Mal, when he said, actually, do we need a revolution in the health system, or do we need actually a reform? So, actually, this is, again, another question I'm putting here in front of you. The third one, actually, to my dear friend, the chairman of the steering committee. Now, we mentioned a lot of data about the paramedics, about the admin staff, and the others. Have we invited them actually to attend us? I mean, why we are speaking on their behalf, actually? Are they here to defend their position? I mean, the finance people, the admin, the paramedics, and the others. Another painful question, but I will leave it actually to the workshop tomorrow.
Thank you very much. Would you like to have a
Okay, I'll comment briefly.
quick comment, please? Yeah.
The good thing is that we don't have to invent anything. We know what we need to do. Other people did the hard work. and they provided the evidence for us, so we know what works and what it doesn't work. And what we need is to start working, and everybody works within his area of expertise. You can't suddenly decide today we will have a new system, good system. System is people.
Thanks. Thank you very much for your patience, actually. Thanks. I know it's been done already. Yes, it's been. Can you please make sure you get the documents for the workshop for tomorrow? And I think I've seen someone is distributing them already. Just make sure you've got one, please. It's just you can read it overnight so you know what's going on. Thanks. For tomorrow. Thank you. No. And also, everybody is invited. Thank you. You know, I've been saying what people telling me. What are you going to say?
I know not most of you are here today, but if you want a specific workshop, would you let us know tomorrow in the morning? You know, put your name in front of it, the workshop you want, and give it to us in the morning.
Do you want me to go ahead and start? Should I start? Okay, great, thank you. Again, on behalf of Mike and I, since this will be the last time we formally address you, I would be remiss if we didn't thank you again for your hospitality and for inviting us into your home. The best physicians do two things. They care for their patients more than they care for themselves, and they make their colleagues better. And again, in our short time with you, it has gratified me to see you do that. When you engage in these kind of discussions, rather than go off and do something else, you're making your colleagues better. I hope something I say will make you better, but just trust this. For Mike and me, as we go back to the United States, listening to you, witnessing the things that you've been through have made us better, and we're very appreciative of that. Physicians for the last 2,000 years, the best ones have possessed two qualities. One is courage. We talked about that last night. And the other one is passion. Passion to take care of their patients. Passion comes from the Greek word passio, which means to suffer. So literally it means that you care so much that you're willing to suffer. Most of us will go through our lives and never really have to prove that. You've had to prove that. So you have earned the respect of me and Mike and so many around the world for doing that. Now, I've been asked what makes a good hospital manager, and it's really very simple. It's just three words, and those words are totus, maior, partes. Totus, maior, partes. That's not English, that's not Arabic, and we're going to get to where that is, but those words come from Libya 2,000 years ago. So what makes a good hospital manager other than totus, maior, partes? The first one is a hospital manager, the best ones, care about two things, and they care about them greatly. And the first one is the doctors and the nurses and the staff in their hospital. They care about them when they get up in the morning. They care about them when they go to bed at night. The second thing that they care about incredibly passionately is their patients, the patients who enter their hospital. Just like when I get on a plane, I trust the pilot and the airline that they've done everything. I don't know it, but I trust them. So the best hospital managers do those things they have to do to make sure that the staff and the patient get what they need. Now, leadership is a fundamental human quality. And you would think if it's true of people all over the world, we'd get good at it. But it's hard. It's very complex. You are seeing that this evening. These are lessons learned over my 27 years of leading not a hospital but a private clinic. And these are lessons learned from the hospital managers that I work with. The most important thing is to get good people to work for you and hire for attitude. You can train them. The first surgeon in my state used to say, the most important thing to success is to want to succeed. So when you're hiring a hospital manager, the one quality and the only quality you care about is, do they want to do a good job? You can teach them the other things, but they have to want it. The second thing is that you have to treat everybody with dignity and respect. You have to have a clear mission as a hospital manager. You have to give a group of people a clear direction. What are you trying to obtain? Is it efficiency? Is it safety? What is it you're trying to get? In the United States, we have the concept of the servant leader, that the best leaders will serve first. The two best hospital managers I've ever worked with would walk around in the middle of the night at 3 o'clock in the morning and ask the staff how they were doing. I'm an obstetrician. I would be the only doctor in the hospital. I would think the hospital was burning down. Why would the manager be in the hospital at 3 o'clock in the morning unless it was burning down? But they were servant leaders. They were not asking anything of their staff that they wouldn't do. So they would literally get up in the middle of the night, walk around, and ask the nurses and the ICU people, how you doing? Are we giving you what you need? So this idea of servant leader, they have to be accessible. They have to be transparent. One thing you'll see as you become more of a global force is that the world demands that you be transparent, that they will not want to do business with you if they don't think, I don't want to fly on a plane if I don't think the airline's not willing to share with me their maintenance and their flight records. If they've got something to hide, I really don't want to deal with them. You've got to be open-minded. We have a saying in the United States that minds are like parachutes. They work a lot better if they're open. When they're closed, you fall to the ground and die. So you want to be open-minded and listen. And you want to mentor. You want to bring along people. You want to act in such a way that future doctors will be better because they know you. And then you have to be aware. The hospital administrator I admire the most always says that he's always thinking about tomorrow. He leaves the day-to-day to people he delegates. You've got to understand that there are trends that are affecting the whole world, not just you and not just me. Healthcare is becoming much more expensive. It's becoming more competitive. If you don't deliver what people need, they will go to Jordan. They will go to Tunisia. They will go to Egypt. As the world globalizes, they will go other places. People are going to demand service and quality. They're going to have choices. As you free up your society, they will have more choices. There's going to be more regulation. That's just the way it is. There'll be more accreditation, more standards. You have to have a hospital manager who understands that and will work with you. And then these are trends that are going on globally. And again, as it becomes more competitive, more expensive, there's more outside pressures on you, you have to have a hospital manager who can deal with that. And again, in the town that I work in, there are 3 major hospitals that all compete for the same patients. And this is a picture of all the different hospitals in this one little area that serves 1 million people. I mean, you can count them. There are about 20. And that's what's coming. That's what will happen. Now, the other thing you have to understand is technology increases, healthcare becomes more expensive. You spend 3% of your gross national product on healthcare. We spend 17%. This is one of my favorite slides here. For you to do a cesarean section, you need 3 things. You need an anesthesiologist, you need a table and a scalpel. In the United States, that won't get it. If I'm going to do a hysterectomy, I need a harmonic scalpel at $30,000 a piece. Not $20 a piece, but $30,000 a piece. And that is the trend from all around the world. Now, the trade-off is, when we do a hysterectomy in the United States, the patient goes home that day and goes back to work a week later. I will bet you in Libya, when a patient has a hysterectomy, she's in the hospital 2 or 3 days, and she goes back to work about a month later. So while technology is a wonderful thing where we do robotic and laparoscopic surgery, it is very expensive. There are certain common traits of great leaders, and this has been well studied. The first one is many of them have overcome adversity at a young age. They've learned to be tough. The second is that they are usually very bright and they communicate well. They know how to talk to people. The third is they like to learn. They are not threatened by people who challenge them because they see that as a way to exchange ideas, and they like to learn. They don't think they've ever learned it all. They've also often been exposed to different cultures through travel or something, so they're comfortable dealing with different situations. And then the other thing is they usually have mentors. If you're interviewing somebody as a hospital manager, ask them who they looked up to. Who are the people that taught them? We all in this room have professors that made us who we are. Hospital managers are the same way. There's somebody that they style their leadership after. If you're trying to hire one or interview one, you need to know what that person was like. Now again, I'm going to show you a picture of my son, Watt. Watt played on a national championship team. They were the best team in the United States for his age group. He was an All-American. Off his team, there were 7 players who advanced to play collegiately, which in the United States is about as good as you can do. But Watt would be the first to tell you that it wasn't all about him, that it was about the team. And we're going to get back to that in a second. Now, these are what we call toxic behaviors of leadership in the United States. We've got a lot of politicians that have them, trust me. But we also have hospital managers. I've worked for 2 of them that have had them. The first one is an inconsistency. If you have a leader or a hospital manager who is moody, that you never know if Monday he's going to be like he is on Tuesday or she's going to be like she is on Wednesday versus Thursday, it just doesn't work. The second thing we've touched on, you can't be closed-minded. You cannot be threatened by new ideas. You have to embrace those. You can't be a perfectionist. People aren't perfect. Patients aren't perfect. Doctors aren't perfect. You just have to get over it. And you have to learn to factor in their imperfections. That's what the airline industry does. They know pilots aren't perfect, so they have come up with guidelines and systems to account for that so nobody gets killed. Another toxic behavior is the focus on the negative. It's easy to focus on the negative, but you've always got to be thinking about the positive. And then toxic leaders can't pick good people to help them because they're usually threatened by them. They worry that they're going to replace them. A really good leader isn't threatened because they know they're a good leader. And then the last thing is they're insensitive. They also feel connected to their organizations. They, for whatever reason, love their organization. They are hardworking. It's very hard to find a good hospital manager who is not hardworking because all the people around them are hardworking. They're perseverant. They don't quit. They understand that all the things that count in life can't be counted. So they appreciate those qualities that may not show up in some report. They know how to renew themselves. They recharge their batteries. They can go, relax, and come back. And they attract strong people. If you have somebody who doesn't have strong people around them, question their leadership. Again, we talked the other day about courage is the virtue which permits all other virtues. And that is so important because a good hospital manager has to be courageous to stand up to all of those entities that will challenge them. And again, in this picture you see different doctors from different places, but the thing they have in common is they are all very passionate about learning. We are teaching a new operation to these physicians at the University of Baghdad, and they are incredibly passionate. Look at the looks on their face. They want to learn this because they know we're there a short time and we have to teach it in 3 days, and they want to help their patients. So look at the concentration on their face. And again, why do we do this? Why do we come to meetings and stay till 7 o'clock at night? There are other things we can do. And we do that because we want the next generation to have it better than we did. We want our daughters and sons to have a better way of life. You have paid, and your colleagues have paid, in many cases, the ultimate sacrifice to make that happen.
Please, 2 minutes, please.
2 minutes will be perfect. Thank you. And again, I just want to read from you from President Obama's acceptance speech when he got the Nobel Prize. And this applies to the people in this room. That for all the cruelty and hardship of our world, we are not mere prisoners of our fate. Our actions matter and can bend history in the pursuit of justice. And those actions have a ripple effect and affect other people around the world. Now, I promised you that I would tell you, again, what the saying means. 2,000 years ago, the Romans sailed across the Mediterranean and settled in this very area that we're standing today. And from that, they learned totus mea partes, which is Latin for the sum is greater than the parts. That in this room, you're all individuals. You have individual needs. You have individual things that are important to you. You have shown that you have the courage to overcome an insurmountable obstacle. But now you have to show the courage to govern. There are two different skill sets. As Dr. Murad said today, it is one thing to tear down a building, not real difficult, just get some sledgehammers. It is another thing altogether to build a building. And that's where leadership and good hospital managers and courage and a passion to do it and making each other better come in play. Thank you.
Thank you, Dr. Williams. Any questions, we will leave them till the end of the session. Now, Dr. Samir bin Ahmed, please. It will be the organization chart of the hospital. Dr. Samir bin Ahmed is a WHO expert.
Shukran. Bismillah ar-Rahman ar-Rahim. Well, it's very difficult to address an audience at 8 o'clock in the evening, but I will try my best in order not to make you sleeping further in any case. The subject also is very difficult, a hospital chart, but the organizers of this conference confessed that they wanted it in between two things, in between a policy of the Ministry of Health and hospital things, which makes it even more complicated. So let's give a try to it. On the policy where I wanted to situate hospitals is more or less the emblem of medical care. In the older China, because we heard a lot about today what is happening in Singapore, what is happening in the UK, what is happening in the US, let's go a little bit to China. In the ancient China, they had family doctors, the big families who have a lot of field around, they have family doctors. The doctor will receive a salary as long as the family is healthy. The day that one of the family members will fall sick, the salary is cut. It will get resumed when the family members will be healthy again. That's exactly what is public health versus medical care. And this is what you have heard today again and again because public health is about to have a healthy and productive population. Medical care is to treat the things. Let me put you another question, because that is the essence of what a Ministry of Health and the Minister of Health should care for. When you have somebody with a very big heart disease and dies, who has killed that person? Is it the heart disease, the coronary, that Rida will operate very quickly? Or is it the 2 packets of tobacco that he has been smoking during the life course? It's the tobacco. It's not the heart disease. So what is easier to treat? Cut the tobacco or increase the number of beds in the hospital for cardiosurgery and for intensive care? We need to think about it again, because that has, again, another implication on what we are going to say. Now, back to the topic of the hospitals, after touching on the public health a little bit. They are the corner of the curative care compared to the public health as part of the health system. It is not true